Welcome to the Manuchehri podcast. Over the last 30 years, it has been my joy to assist humanity in aligning with their magnificence so they may heal, discover their natural gifts, and communicate with loved ones living on the other side. May you also experience delight while we dance in the powerful, intuitive world of energy. Let's get going. Welcome, everyone, to where energy meets the divine. I'm your host, Marie Manuchehri, and today I get to do something that I don't do in every podcast, but where I get to interview someone who I believe is on the leading edge of thought. So this is one of my favorite kind of special days where I get to listen to a wonderful, amazing human being who has great insight and information to help the human race to continue their evolutionary process and to be happy and fulfilled, all the things that we all deserve. So today I'm interviewing my hormone doctor, Dr. Alisha Ghajar, who actually was raised in Texas, and her family had a long history of obesity and health issues and dietary problems that were not addressed even with dietary changes. So she became very excited about nutrition and health and well-being and went to Colorado State University and got a degree in nutrition. And then she got all excited to learn more and came to my part of the world, to Kenmore's Bastyr University, one of the most celebrated universities in the world in naturopathic medicine. I've always lived almost across the street from Bastyr for some weird reason and fell in love with women's health and hormones. And so that's what she specializes in now. So she created this huge toolbox, from her nutrition degree to hormones, and even recently got a certification with the Menopause Society that does a ton of research on women's health. I mean, real longevity research that they've been doing for a long period of time. So when she's not treating her patients or doing a podcast with me, she can be found cooking, spending time with her husband and her daughter, weight training, and writing. So welcome to the show. It's lovely to have you.
Thank you, Marie. I really so value your podcast. I listen all the time. It's just an honor to be here with you.
Oh, well, it's mutual. We're going to have a lot of fun. So what was it that got you really into women's health? Because that is your specialty.
Yeah. And I really made it my specialty actually after graduation. And it was during my residency program after graduation. And really, it was, I think we often will treat the conditions that affect us more personally. I was 41 when I had my only child. And I think a lot of women nowadays, we are having children older. And I sort of went from childbirth to perimenopause. It just was very quick, very immediate. And, I received actually quite a bit of training in perimenopause and menopause, but even I didn't recognize that that's what was going on. I just felt like my body was falling apart all of a sudden. And what is this? And it was really disconcerting. Once I figured it out, once I got the care that I needed, I started noticing how many of my patients had the same complaints. And I didn't realize that's what was going on for them. And so I started paying more attention and I started hearing their stories, which were ghastly, just hearing stories about, just being dismissed or feeling like, being made to feel like they were crazy or, this is all in your head, or asking for hormone support and being denied for, no apparent reason, really. And I couldn't take it anymore. So the thing I think that has kept me doing this work is that when women receive the support they need, that is in alignment with their goals, with their values, they thrive. They just take off. And it makes me so joyfully happy to be able to do that. So every day I get to have fun. By helping women feel better. It's great. I don't have a really challenging job. I'm not dealing with end of life care or, things that are really heartbreaking. I mean, we have moments in medicine, but I get to help women feel so much better. And it's the best thing ever.
I think when people do what brings them joy, it never feels like work. It's
Right.
just It's your passion. You get excited about it. You love hearing the stories and you're learning because you're impassioned by it as well. So congratulations. I wish that for everyone. Yeah. So, so when someone walks in your office, because you just touched on this, and they have all these symptoms and complaints, and they've been to their own practitioners, and no one has even brought up the topic of hormones, which is pretty common, in my opinion, in my experience. I had a dear friend who first they put her on antidepressants, and I said, no, it's your hormones. Then they even did a uterine biopsy, which was perfectly normal. Then finally, she decided to go see an ND who determined it was her hormones, and it really helped her so she could get off the antidepressants. And years ago, when I was a nurse, when we'd have women who came in, maybe were in their 70s, many of them were on Valium. Their doctors put them on Valium for menopause for, like, let's say, women a few generations ago, which is kind of sad. So when someone walks in your clinic, they've been feeling dismissed, unheard about their hormone symptoms, how do you approach this differently than their other practitioners?
So say they've had that experience, they're feeling a little bit defeated. I do a really thorough history. I have a hormone questionnaire that they fill out before I ever see them. It's pretty extensive. And many women tell me that they didn't realize how many symptoms they had until they filled out the questionnaire. And they didn't realize how many symptoms relate to their hormones. So I review all of their health history actually before they ever come in, everything they provide me. I review their hormone questions that I've already, asked them. And I love to start with their goals. What do you want for your life? What's your goal? How can I help you here? Because I'm not their primary care provider. That's not my role. I'm here really just to help them optimize their wellness. And so I find out what their goals are. For some women, it's I can't sleep. All of a sudden I can't sleep. And that's the worst thing ever. And for some women, it's, I felt fine. And then my libido collapsed just like that overnight. And it's really distressing for them and their relationship. For some women, despite everything they've been doing, they are gaining weight all around the belly. They don't know what's happening and nobody will help them, or they're just being told to exercise more and they're like killing themselves in the gym. We find out like what is the one thing that's really bothering them. And then, I ask them, what do you know about hormones? Because they usually are coming to me assuming that I'm going to give them a hormone education, or they know I'm a prescriber. That's why they're here. And so, what do you know? What are your sources of information? Do you have any fears around hormones? What questions do you have right off the bat that I can ask you? And then once that's kind of cleared, I usually will take them through, this is the experience of going from your reproductive years through perimenopause into menopause. This is what we expect to see. These are some of the experiences women have. This is what your hormones are doing. I focus on 3 different hormones. This is what they're all doing. And this is how we can support you. And based on their symptoms and their lab values, they both matter. One is, they're not mutually exclusive. So we put them in context together and I make recommendations based on my own experience clinically, based on the guidance from the Menopause Society and other organizations, and based on their values. And not every woman I see wants to be on hormones, and that's okay. And I don't actually recommend it for every woman I see. But what I don't want is women to make fear-based decisions. And I think that's unfortunately, since the Women's Health Initiative study was published 20 years ago, we've just been making fear-based decisions and not based on science. So, I present them with the actual information, what science shows us, and then they make their decision. It's up to them in the end.
Wow. So if you have someone who has low hormones and they have all these symptoms, or, I love how you say, what's the one thing that's driving you the most crazy, or causing the most problems in your life? Because that's a great starting point, right? Because interesting enough, you fix that one thing and I think everything else has like a ripple effect, right? So
absolutely. Yeah.
That's amazing. So what do you do for the people who can't take hormones? Like you're not recommending it for them or they don't want to. What are the options? I get this question a lot from clients.
Yeah, yeah. Well, that's a complex question. For one, I'll say there are actually very few people who cannot take
Hmm.
hormones.
Hmm.
There are far more people who actually can. In the old days, there were many reasons why women were told they couldn't take hormones, like high cholesterol, which is absurd. That's not true. Like I had a grandmother who died of breast cancer. That's actually not a contraindication. There are many reasons why we used to withhold hormones that don't pan out in the research. So
Right.
more women are actually candidates than they probably think. And then if they actually can't, it depends on what the issue is. Maybe the key problem for them is vaginal dryness. Well, we can give you vaginal estradiol. It's very low dose. It's not systemically absorbed. It's safe for literally everyone
Mm.
except potentially a particular type of uterine cancer that's quite rare.
Mm.
But everyone else, no matter what, can use vaginal estradiol. So if that's your issue, we have that option. If the issue is sleep, maybe you don't need estrogen, maybe progesterone would be adequate for you. That's potentially an option. There are many, many herbs
Right.
available that support sleep. And, being a naturopath, I dabble in both, herbs and pharmaceuticals. And, magnesium is a mineral that is wildly helpful for sleep. Sometimes it's just lifestyle oriented. Maybe, if you don't want to or can't take hormones, there are lots of things you can do to support yourself. You can stop smoking if you are. You can stop drinking alcohol if you are, because we know that that causes a lot of inflammation in the body. It definitely makes hot flashes worse. You can prioritize your exercise. I mean, there are so many
That's great.
tools. Yeah, so many tools at our disposal.
I think that's really wonderful because I don't know how to answer that question for my clients. I refer them to people like you because I don't know. Besides herbs, I have no idea, and I don't know all the herbs that you would like or would be in your best interest, right? So, why might someone work with an ND for hormone therapy instead of an MD? What would be, I can think of a bunch, but I want to hear what you have to say.
You know, the way my viewpoint these days is I just want women to get care. I don't really care who they work with as long as their practitioner is well educated and has, nobody gets a comprehensive menopause education in medical school, whether that's MDs or NDs or nurse practitioners or midwives. Nobody's getting comprehensive menopause care in school. You have to be trained after you graduate. You have to do the CEs, you have to go to the conferences, you have to take the courses, you have to read the books, you have to take the exams, like you have to study independently. And so as long as they're well educated, I don't care who they see. So why would somebody come to me instead of an MD?
Hmm.
I mean, sometimes people tell me that it's usually a referral from a friend or a relative, like maybe they unfortunately felt dismissed by their primary care doctor. And, I have a lot of empathy for PCPs. They have to
Sure.
manage cancer screenings
Right.
and so they have to manage a lot. And they're
Right.
usually, being crushed by insurance pressure. But if they have felt dismissed by an MD, they're just more likely to try somebody different,
Hmm.
And I think they also probably, if people have a little bit of fear around hormones, they might trust an MD more just because we are educated and comfortable with alternatives if
Right.
necessary. But, I think anybody, honestly, any provider who is educated can provide good menopause care. As naturopaths, we tend to also address, diet and lifestyle. So we talk about nutrition. It always comes up. We talk about fitness. We talk about stress. We talk about relationships. We talk
Hmm.
about your sleep. It's pretty comprehensive. So that could also be a driving factor.
One of the things that I thought of, just because I've had the experience of, going on hormones and testosterone later, not when I first started hormones, is that you did a lot of testing to make sure that the testosterone was working in a positive way in my body and that all my hormones were working in a positive way. Once I'd been on the testosterone for a little while, not very long actually, which I don't think those tests are mainstream in with MDs or modern medicine. Granted, sure, if they've done a lot of research, then they may want to do those. But I was really impressed with that because it made me feel even safer that my body was responding in a healthy way,
Mm-hmm.
that we could feel comfortable in the dosage I was taking and how I was metabolizing hormones in my body. So that's something I really appreciate, that maybe an MD doesn't have the time or isn't aware of some of those tests. I'm not sure.
Yeah, that's a good point. I didn't think about the testing. Naturopathic doctors get a reputation among phlebotomists for
Yeah.
ordering lots of tests.
Yeah. I mean, every time I go to LabCorp, they go, so is this for your naturopath? I'm like, yes, because they need like 12 vials, right? Yeah.
And, I don't want to scare anybody away, from going to see a naturopath if they're afraid of needles. But, so menopause itself is a really crucial time in a woman's life where a lot of your physiology is changing, and it's an important time for illness prevention, disease prevention. And if we have the opportunity to, maybe a woman has felt generally healthy, and so she hasn't been to a physician for years, but now she's having these menopause symptoms and she comes to see me. I want to make sure her cholesterol is good. I want to make sure her basic nutrients, nothing, out of whack, but how's your vitamin D? How's your iron? How's your B vitamins? Like, how's your cortisol? How's your blood sugar looking these days? Because we know as hormones decline, all of that can just become really out of whack. And then, yes, for hormone therapies specifically, there are ranges where we feel like we're safer. And then also there are ranges, for example, I'll just give you an example, estradiol. I want it to be at least like a 60. Like on my test, I want it to be a 60, a level of a 60, to make sure your bones are protected. So a woman, who's 55 years old and is not really making any estradiol anymore, if I'm giving her estrogen therapy, I want to know that I'm giving her enough to protect her bones. And I want to make sure I'm not giving her too much, that might cause problems down the road. So we do have ranges that we like to stay within. And then there are, I think you're also alluding to some more advanced tests that are options if we have concerns about how a woman might metabolize her hormones. There are other tests we can order that are definitely not mainstream. They're available.
Right. Like the Dutch test is probably one of them, right? Which it's kind of weird to do dip, this strip into urine at certain times over a 3-day, I think 5-day period actually, because I like to take a certain dosage of testosterone, which is a little bit higher. And you wanted to make sure that it was metabolizing in my body well. And thankfully it is. So yeah. I've never heard of the Dutch test, and I've seen a naturopathic physician for like 35 years, or even probably when I was a kid, my mom took us there as well, but I don't remember those appointments as well, but I'd never heard of it. So there's all kinds of interesting tests that MDs aren't taught in school that could potentially give us more understanding or safeguard, right, about our health and well-being.
That's true. Yeah. And you wouldn't, a physician who doesn't do a lot of hormone therapy probably wouldn't ever order a Dutch test. It would be really reserved for those of us who do a lot of it. And it's for specific people. It's an out-of-pocket test. It can be expensive. So it's never something that we have to do. Hormone therapy can be as expensive or as cheap as you want it to be.
That's true. Yeah, that's true.
Like you can, there are ways around it, but it's a useful test.
Well, since we're on the topic of tests, Can you explain the pros and cons of saliva, blood, and urine testing? We kind of covered some urine testing, but I have never had a strong intuitive feeling for testing hormones with saliva. So that has never happened to me. No one's ever asked me to have my hormones interpreted through saliva, but I've had many friends and clients whose practitioners have them do these saliva tests. But from an intuitive perspective, I can tell you, I don't have like, yay, saliva is the way to go. I don't have that feeling. I'd love to know. And maybe it's different. Some people maybe will test better with saliva. I don't know. But intuitively, I don't have a like, yay, kind
That's
of
so
feeling.
interesting that you say that because I feel the same way. And you and I have had conversations about intuition in medicine. Oh, and by the way, I'm taking your advanced medical
Oh,
intuition.
thank you. That's so
Um,
kind. Thank you.
but I, I don't think I'm probably the best expert to really thoroughly answer that question, but I'll tell you how I practice. I don't routinely do saliva-based testing because it's not accurate if a person is on hormones. It's great
Mm.
if you aren't, but it's not great if you are. Also, there are plenty of people who aren't great candidates for saliva-based testing if they actually, there are autoimmune diseases like Sjogren's, some other conditions that can cause dry mouth, and saliva-based testing can actually be a challenge for them. So I've just never, and I just never have found them to be necessary in my practice. I use blood markers most often. So just actually, frankly, very standard blood tests you can get at LabCorp or Quest. And there are published ranges. Most of the research we have is based on blood tests. So I feel very comfortable with those ranges. And then the urine test, the only urine test I really use for hormone management is really the Dutch test. I don't fly anyone's flag. So, if there was a better option, I would probably switch to it. But I like that because it tells me how do you excrete the hormones out of your body, which I like. I want to know that. There are some cases where I want to know how do you get this out. Too much estrogen is not a good thing. How are you metabolizing this? There are several metabolites that some of them are pro-inflammatory. Some of those metabolites are supportive. And metabolites, that word just means how your body converts chemical, whether it produces it itself or whether we're giving it to you, through hormone therapy. How does your body convert that chemical, that molecule, packages it up in a way that it can get rid of it? Because your body exerts
Mm.
its own influence on literally everything you take. So it's
Mm.
going to add methyl groups, right? It's going to do all kinds of, it's going to use a sulfur, pathway. There are all kinds of pathways that the body will use to keep itself in balance.
Mm.
And I want to know how you get rid of things if I have any concerns, like if hormone therapy causes certain unusual symptoms, or maybe you have a strong family history of some conditions that I might have concerns about. That's when I would want to know about how you metabolize. I've just never found a need to measure in the saliva, but I
Yeah.
remain open. I have to
Sure.
take many, many, many continuing ed credits every year. And, sometimes they're about saliva and I listen,
Sure.
and I just haven't felt compelled yet.
Yeah, I just, it doesn't feel accurate, is how I felt. I didn't really know the distinction because I'm not a naturopath. I've never studied holistic medicine. That that once you're on hormones, it's not as accurate, but maybe it can be accurate prior to hormones. And people need to be tested regularly when they are doing hormone replacement to see how it's working in their body. Has there been any changes? Because hormones continue to deplete. It's like a lot of people think, oh, I went through menopause, I'm done. I'm like, Right. They're just going to continue to go down and down and down and down. I mean, I don't know what my testosterone was prior to the age of 64 when I met you, but my testosterone level was, in your words, zero. I had so little in my body that it wasn't really measurable. I think I had 0.05 or something like that, some very small number.
It was, I don't want to divulge your own medical information, but since you mentioned it, yeah, it was
Yeah.
really low. Yeah.
Yeah, it was really low. Right. So things you have to continue testing because your hormonal, like we know my testosterone is zero without testosterone. It's not going to get any lower than that. But some people will continue to reduce their estrogen or their progesterone or other hormones in their body. And so they have to be monitored.
Yes. And, I think, so the trajectory, and this is something that I find that I educate patients on a lot, is like, what is even happening with my hormones? What's the trajectory? We don't know. Our sex education is so inadequate in that, young girls and boys are not getting educated on what are your hormones doing for the remainder, like your whole life. A woman can spend half her life in menopause,
Right.
and her life is not over. We're living longer and longer.
It's so true.
Yeah. So like testosterone peaks in your 20s
Mm-hmm.
and it declines thereafter. It does level out in your 70s usually, but it's never as high as it was in your 20s. So that one and it doesn't fall off a cliff like estrogen and progesterone do, but it definitely goes through a decline after your 20s. And then estrogen, does this wild up and down oscillating situation through perimenopause. Sometimes it's gentler for some women than others, but people have different experiences. And then once you hit menopause, it's done. It's low. It's not coming back. It's going to be low forever. And that's a hormone you had exposure to your entire life until finally it ran out. But you might have half your life left to live,
Right.
without this key hormone that protects your blood vessels and your brain and your bones and your metabolism and your immune system. You have receptors throughout your body for estrogen. And then progesterone usually in perimenopause declines before estrogen because it's made by the shell of the follicle, the corpus luteum, that
Mm-hmm.
that the egg ovulated out of every month. That's what's
Mm-hmm.
making the progesterone go high in the luteal phase. That's why we call it luteal phase. And so as you start to run out of eggs, you start to run out of progesterone. And relative to estrogen, it can be quite low in perimenopause, which causes the sleep disturbances, the anxiety, the rage, the irritability. A lot of that can be traced back to progesterone.
Wow. I didn't know
So,
that about the anger and the frustration
mhm.
is progesterone related. I did not know that.
I mean, it
Huh.
can be estrogen too, depends.
Mm-hmm.
But yeah, often, I mean, this is why it depends on, it's not just your labs, it's your experience. Often in perimenopause, which just means before menopause, right? In perimenopause, often we just need to give progesterone.
Right.
Estrogen's, high or normal, and we just need to boost your progesterone to support your body and that
And
balance.
that could begin even in one's 30s, right?
Oh,
Like,
yes.
right? Yeah. And in
Yeah.
fact, it's really great if younger women would have their hormones checked in their 30s so they can kind of see what
Mhm.
their baseline is and maybe start progesterone and continue to get great sleep and maybe not be as irritated if that's an issue for them, so that things can be monitored so they can start and not wait until their 50s or 60s to start hormone replacement therapy.
Yeah, my favorite people to see are actually younger women in their late 30s, early 40s and I just saw somebody this week like this, who just want to check in. They don't have symptoms yet, but they're starting to wonder, like, is this weird thing that's happening maybe related? But they're
Yeah.
otherwise healthy. And they just want to get a baseline. They want to know, how can I prevent decline. They want to get a read on their hormones while things are still kind of behaving in a regular rhythm. That's my favorite. They're not ill. They're
Oh,
just
right.
check in. Yeah.
As they should, as they should. So before we go, because I want to talk about modern medicine's hormones and bioidentical and your thoughts and opinions about those, although testosterone can only be bioidentical, right? In the United States anyway,
Mhm.
which is interesting. But I wanted to talk about how hormones, you already brought it up, but how they really can protect the body. Like they're part of the immune system, which was brand new information to me. It makes total sense considering that hormones talk to every organ in your body and all of your physiology. But for some reason, it took me a while to recognize, like, oh, yeah, they're supporting your immune system. So that means it could protect us from diseases, including cancer, which is interesting because one of the reasons why estrogen was blacklisted until recently is because they said it caused cancer. But there's actually a ton of research that indicates that it protects women, maybe men too, of course, from potential cancers.
Yeah, that association or that misinformation, I guess, about estrogen causes cancer
Mm-hmm.
is it's so pervasive in our culture, and it's really too bad because you know a whole generations of women have been either
Robbed.
denied, yeah, they've
Yeah.
been robbed of it, and they have every right to be angry about that when they learn now that actually that study that scared everybody turned out the estrogen only arm of the study actually had lower rates of breast cancer. So
I
the
didn't even
study,
know that. Oh,
yeah.
wow.
So about breast cancer. So the Women's Health Initiative was it's to date the largest, I believe it's the largest study we've ever done. I think, don't quote me on that, but I think it's the largest study we've ever done in the United States, but it's definitely the largest study on women's health we've ever done. Very expensive study, long-term study. The researchers were concerned about, so doctors prior to this for decades had been prescribing estrogen, and at the time, the only estrogen available was conjugated equine estrogen, Premarin. They had been prescribing it for cardiovascular disease prevention. And so and then there were questions about could this potentially cause cancer? And so the researchers set out to study, does it actually prevent cardiovascular disease? Is there a breast cancer signal? They had these questions. There were several secondary endpoints. The researchers unfortunately stopped the study early because of some potential for cancer risk that they saw in the data. Unfortunately, before they published the study, before doctors had it in their hands, so this is before the internet, right? So medical journals got mailed to you. So no reporters had it, no doctors had it. The researchers launched a press conference and said,
Wow.
we've stopped this study early because we found that it causes breast cancer and likely dementia, and I think stroke. So this terrified everybody. Doctors have been prescribing it forever, and we're like, oh, the patients are calling, like, why are you giving me this? It's going to kill me. Like, so many women were taken off of estrogen therapy. And then for, all the doctors who were educated after that were taught in med school, that you should not be giving hormone therapy if you cannot all help it, because it will probably cause stroke and breast cancer.
Wow.
A reanalysis, so the actual study showed that the culprit was not estrogen. It was the synthetic progestin, which we have no reason to use today. So the study had a few arms. You received either a placebo or you got conjugated equine estrogen. If you had a uterus, you also received medroxyprogesterone acetate, or MPA, a synthetic progestin. And if you didn't have a uterus, so no reason necessarily to protect, your uterus from hyperproliferation from estrogen therapy, then you only got conjugated equine estrogen. The group that had the higher breast cancer risk was only the group that got the combination of the estrogen and the MPA. And the group actually that had no medroxyprogesterone acetate had lower rates of breast cancer. There was also no increase in stroke. So,
wow.
and you know, even with that, we don't prescribe. We try actually to keep women safe. We actually try, and we being like those of us who do menopause medicine every day, we actually try to avoid oral estrogens generally if we can, because there is a small signal that oral estrogens might increase stroke risk potentially. So we just try to avoid that, especially in women who have increased clotting factors or a genetic risk or some other reason. We can just avoid that by not giving them oral estrogen at all. We also try not to prescribe conjugated equine estrogen. We try to prescribe what is bioidentical, which is available in commercial pharmacies and compounding pharmacies, and it's 17-beta estradiol. We just prescribe what your body recognizes as being biosimilar. We also don't ever need to prescribe MPA because we can give you oral micronized progesterone, available everywhere, very affordable. It's exactly what your body makes. So, you know, even with the small signals of warning from the Women's Health Initiative, there are ways around it. We know that transdermal estradiol is safer than oral. We know that bioidentical progesterone is safer than synthetics. And there are plenty of ways that we can keep women safe while we give them the hormone therapy that hopefully improves their quality of life and prevents long-term damage.
Sounds amazing. Absolutely wonderful. I had a client who, when she was going to be inseminated, or so they were gathering eggs for the process, and they found a tumor on one of her ovaries. Turned out to be cancer. She had the ovary removed, and she wanted to still take hormones, which is not recommended, you know, if you've had cancers or particular types of cancers. But she decided to take bioidentical, and this was decades ago. And she's never had a recurrence of any cancer. Her other ovary is perfectly healthy. So I just think there's a lot, and she used her intuition. This is what because I didn't even, because it made me nervous even. I'm like, I don't know, because this was a while ago. I didn't know very much about hormones, like the little bit that I know today, but it was a decision that she made. I think it was an excellent choice for her because it probably protected her body from future cancers as well.
Yeah, the argument that estrogen causes cancer seems absurd to me on just a logical basis, given breast cancer most often occurs when women are in menopause and don't have estrogen available. You know, like, and in pregnancy, our estrogen is never high as it is in pregnancy. And it's not like we see an uptick in breast cancer in pregnancy. So I think it's a little bit of a narrow argument that doesn't really make sense broadly. And when we consider all the research, I have patients who have had breast cancer, and we have, you know, we dig into the research. I present them what I know, what papers show. I show them, you know, society viewpoints from the Menopause Society, the, you know, American Cancer Society, et cetera. And most recommendations, depending on the cancer, depending on the history, depending on the treatment, most will say that it's a decision that should be made between a woman in concert with her oncologist, where, you know, do the benefits potentially outweigh the risks? And if that answer for her is yes, that should be her choice. And we should try to deliver it as safely as possible. And, you know, we continue to do whatever monitoring is necessary. But to blanket say, you know, no, estrogen causes breast cancer, it's just, it doesn't work that way.
Amazing. Just amazing. And you probably know, because of whatever research that's been put out there, because testosterone and I guess estrogen too protect the brain.
Oh, yes.
Right? I mean, you can tell even when you take either one of them, but in combination, if you need them both, you can really feel your mind coming a lot clearer online, sort of speak. What about dementia? I mean, I think we're going to see a large reduction in things like Alzheimer's and other forms of dementia, which is the highest incident is in women, I believe, if I'm not mistaken.
I believe so.
Okay. I think we're going to notice that reduction because more and more people, men included, are going to start to take hormone replacement therapy. And I think it's going to protect their brain and we're going to see less dementia.
Yeah, dementia risk, I mean, it definitely increases in women in menopause. Currently, the FDA does not, and all the societies, they do not recommend prescribing hormone therapy for dementia prevention. However, we know that it prevents.
Right.
So there is a researcher, and I don't recall her name, which is a shame because it's fascinating research. But there is a researcher who published the changes in the brain. And actually, there's a great book called The Menopause Brain by Lisa Mosconi. Fabulous book if anybody's interested in the brain and hormone connection. But when women go through menopause and they don't have estrogen on board anymore, there are so many estrogen receptors in the brain. Estrogen regulates glucose metabolism, including glucose uptake into the brain.
Which it needs a lot of.
So if you take estrogen away, and now we have impaired ability to get blood glucose to the brain starts to, for lack of a better word, eat itself.
Wow.
It literally remodels. And, if a woman happened to be on a ketogenic diet, it could use ketones instead. But in absence of that, her brain, her white matter will start to decrease because it will save itself to the best of its ability. But that might mean it has to do a little bit of self-metabolism.
Wow. Kind of like frontal lobe dementia, where it just progresses very quickly. And I mean, it's a terrible disease. So I think that's fascinating. I look forward to, of course, I'm sure you're the same way. I'm just someone who doesn't have to wait for all the research to come in. If something feels good to me, I'm like, okay. And then the research comes later and validates, your intuitive hunches or your awareness, especially with your nutrition background. And you're wonderful at nutrition too, by the way. You're very great at it. You're welcome. Okay. So now this discussion about compounded versus not compounded. And again, testosterone. Is this for men too? Only men can take bioidentical as well?
I mean, men usually get prescribed injectable testosterone.
I know. I don't like that.
Yeah, it's just, it's interesting because there's so many, I'm always for what works for your lifestyle, right? What can you deliver what's the best way to deliver the dose you need that fits into your lifestyle? Like all I want is for people to get the treatment they need, right?
Right.
And so men need a lot more than women do. The female dose of testosterone when I'm prescribing it is 1/10 of the male dose.
Wow.
1/10. So
that's why they want to do pellets. Then it makes more sense if they put that in sub-Q and then it starts to dissolve. My thought process is, though, everyone's unique and their body's ability to metabolize. So what if somebody's body really metabolizes the majority of those pellets quickly? Because testosterone does have a risk for blood clots or, hemorrhaging, things of that nature.
Yeah, the pellets are interesting. I mean, on one hand, I think it's great that it's an option for those who want something they only need to do every 3 months, because I think it lasts for 2 to 3 months. What I don't love about it is, and I don't offer pellet therapy in my office. It's not recommended by the Menopause Society, and I personally have not seen it to be worth it. You do have to do a small incision in office. I've received a pellet. Almost everything I've prescribed, I've tried on myself.
That's cool. I think that's cool.
Unless it was something I should not take. But, to have the experience, it left a scar. Like I have a scar now on my hip from this silly little pellet. So anyway, that's there. So you have to do a minor office procedure. And then once it's in, you can't take it
Right.
out. The
Stuck.
pellet stays there until it eventually breaks down. So if you're having negative side effects of it, you have
Right.
to wait it out or take a drug to counteract the side effects, like
Right.
spironolactone, because now you're losing your hair or whatever. And then really what I don't like about pellet therapy, especially for women, is that it spikes. It's just there's no way around it. It's going to spike your testosterone super high and then slowly decline. And we have to pick a pellet dose that will,
Mm.
last, hopefully about 3 months. But that means, you're going to have a really high level of testosterone before we get to the goal range. And then it's going to drop after that. So, I've done it before, and the increases women can experience in acne and weight
Mm.
gain,
Mm.
like nothing irritates a woman more than giving her something that makes her gain
Right.
weight. But acne,
Yeah.
weight gain, potentially male pattern hair loss, hair shedding, if the dose is too high. It's just I don't like prescribing things when I can't dial in the dose. I don't like that. So I like for women, I like to do daily therapies, and there are lots of options, but we can tweak the dose. We can fine tune it so
Mm-hmm.
specifically for,
Mm-hmm.
down to half a gram. I mean, we can make it really, really dialed in, which to
Love
me
it.
is so much better. You don't
Love
have
it.
to have negative side effects.
Right. You don't have to. And
Mhm.
I don't think that many people do have negative side effects, if they're with someone who's really educated, like you said,
Mhm.
in hormone therapy. You just feel better and better and better, actually, because your body comes online, and
Yeah,
everything starts.
as long as we're in the right range for that person,
Mm-hmm.
then I rarely actually see negative side effects. And if we do, they're usually quite minor, because even then we might be just slightly outside the level that they need, and we just dial back the dose. So we're not experiencing any really severe side effects when people are appropriately monitored.
Right. Right.
Yeah.
So I probably don't know this exactly truthfully, but in my mind, I think that modern medicine's hormones, and I'm sure there's a better title for that, is like horse urine, because that's what I just remember. They're collecting urine from horses and extracting the hormones. But how is it really created in pharmacology? Not bioidentical, but the other hormone.
So let's use estrogen as an example. So estrogen in the beginning was extracted from pregnant horses. It's
Yep.
true.
Yeah.
Premarin. Premarin stands
Right.
for pregnant mare urine.
Uh-huh.
And I don't know who had that idea. I've never dug into the history. It seems like a harebrained idea, but whoever did it, it actually worked very well for the generations of women who took it for many, many decades. However, conjugated equine estrogen doesn't just contain human estrogens. So human beings make 3 kinds of estrogen, and a 4th is made by a fetus while you're pregnant.
Mm.
But while not pregnant, a woman's body makes 3 kinds of estrogen: estrone, estradiol, and estriol. E1, E2, E3. Pregnant horses apparently make a lot of other estrogens that the women who are human beings do not need. Therefore, it is not bioidentical, because it is not identical to the chemical compound that women's ovaries make. So that is not a bioidentical. It is a natural product, quote unquote, and that word is not a regulated term.
Right.
The word bioidentical is not regulated either, but natural just means it came from nature, right? So you could say that, a pregnant horse's urine is natural, but it is not bioidentical.
But also horses are fed medicines and they eat hay with pesticide and herbicides in them.
That is true.
And, urine is supposed to release some of your toxins, right? So it just doesn't feel good to me whatsoever, but I love your description of it. So please carry
No,
on.
I agree. I have never had the need to prescribe it, and they still make it, Marie.
I believe
That's
it.
the funny part, because it's not a complicated, it's actually not a complicated process to make estradiol. So anyway, but they still make it for whatever reason. And unfortunately, in most studies, that's what was used in most research, which is a little frustrating because that's what none of us are providing. We're not prescribing that at all. So I actually looked into this. I looked into how is 17 beta estradiol made, which, to be clear, no matter if you're getting an estradiol patch, an estradiol mist, a gel, a cream, a vaginal ring, an oral pill that is 17 beta estradiol, it's all 17 beta estradiol, which is exactly what the human body makes. Progesterone, the same, no matter if it's a cream, if it's an oral tablet, as long as it's progesterone and not something else. The two of them, 17 beta estradiol and progesterone, are made from plants.
Right. In the
And
compounded, or for everyone.
Actually, even in
Wow.
the commercial. And here's
Ah.
yeah. And the process is generally they'll take a plant, it goes through a chemical process in a lab, because wild yams, which is what we get some hormones from. Wild yams in and of themselves, you're not going to take enough wild yams to get hormones.
Right.
So they'll take the original plant compound, and it will go through a chemical process to purify it, to esterify it, to do whatever it needs to do to look identical. If you were to draw out the chemical molecule, the molecular structure would be identical to 17 beta estradiol or progesterone. And, there are different ways of making it, but they all start with a plant. Some of them, I just learned this, might start with a bacteria or a yeast. But for the most part, they start with a plant. It goes through a chemical process. And, what the compounding pharmacies get that they then compound, they get USP 17 beta estradiol. USP means United States Pharmacopoeia, which means it's been tested for impurities. It's been tested for accuracy, that it actually contains what it says it contains. It's a powder. And then they put it into whatever form we need it to and whatever dose we want. So the real benefit of the compounded hormones is just that I know exactly what's in it. I don't have to worry about any excipient ingredients. If somebody has an allergy, we can keep that allergen out. For example, some people have an allergy to soybean or corn, and sometimes commercial progesterone pills have corn or soybean in them. So I can tell my compounding pharmacist, this person has these allergies, and they'll say, oh, no problem, we'll make it with this other oil. And
fascinating.
That's the real benefit of that. So and some people, the patches, the starting patch dose is 0.025 milligrams of 17 beta estradiol. The next dose is double that. Well, there is an intermediate. But if somebody needs a very specific, maybe even less dose, what are they going to do? Cut a patch in half? That's really hard to get accurate. But I can tell my compounding pharmacist I need this exact dose. And they can make it. So they have pros and cons. I think the key is that they're all starting with the same USP pharmacopoeia product and then packaging it in a way that might be different. You have a lot less flexibility with a commercially produced product than with a compounding product. Your insurance is not going to cover a compounded product usually.
Right.
So if somebody wants to use their insurance, I'm happy to prescribe it so that they can get access to that product. Wow. And if they don't respond well to it, we just move them over to a compounded product, and that usually solves the problem.
I think that's fascinating, especially about the corn and the soy, because I think a lot of people do have allergies, honestly, to certain types of foods. And I wouldn't even think in my mind that, oh, corn's in there or soy's in there, that maybe that's why I love compounded so much,
Mhm.
because it can be controlled, like you said. Are compounded pharmacies more regulated than the other pharmacies, or do you think it's the same sort of regulation?
No, and that's one of the big arguments that my MD colleagues will make about compounding pharmacies. They'll say, well, it's completely unregulated. And they've been educated not to use compounded pharmacies.
Right.
However, it's not that they are completely unregulated, it's that they are not regulated in the same way, right? And they're more regulated on a state by state basis, but
Mm.
they are subjected to rules and regulations that they have to follow. And a good compounding pharmacy will provide you with, their chemical analysis sheets that show, that this product has been tested free of mycotoxins, of heavy metals, of whatever. And I have really close relationships with a lot of compounding pharmacies. They are a wealth of information. So it's not that they aren't regulated, they're definitely not more regulated, but they don't undergo the same FDA oversight as like a commercial producer
Mm-hmm.
of, medications
Mm-hmm.
would be subjected to.
Fascinating. I mean, really, the whole top. I mean, like you said, we said this before we went live. We could talk about this for hours, right? For hours. So, testosterone is considered a scheduled drug,
Mm-hmm. Schedule 3
right?
drug. I have a DEA license purely to prescribe testosterone. Yeah.
So that's why some naturopaths don't prescribe it, because they don't have the license, so they can't prescribe it. And we're one of the few countries that makes it a scheduled drug. And I know this because when I was traveling to Ireland and I was going to take my testosterone, I'm like, well, I got to check on the website. Do I need to keep my pills in the same bottle or whatever? So I get on the website and they said, no, Ireland doesn't consider it a scheduled drug.
Yeah, the reason it's scheduled is because of doping scandals.
Oh, for athletes?
Yeah, for athletes. And so
Mm.
there are anabolic steroids that make people have superhuman strength. And because testosterone is a steroid hormone, they got scheduled just like the doping drugs. But your body makes it. It's absurd to me to call a substance your body makes naturally a controlled substance that I have to have a DEA license to prescribe. But I think that
Crazy.
actually might be changing, Marie. I think the
Ooh.
FDA might be reconsidering.
Ooh. Okay. So there are just a couple of cool, positive things with our interesting healthcare right now in the federal government, right?
Wow.
A
Yeah.
couple few, a couple few things. Okay. So what advice do you have for people who, regardless of their age, because I've heard you say it's never too late to start hormone replacement therapy,
Mhm.
which is
Yeah.
amazing.
It's not ever too late. It just depends on what your goals are, and is hormone therapy the answer?
Mm. Right, because maybe it isn't the solution to the problem that they have. Oh,
Right. Right. Yeah, it's very nuanced. And was your question more about like what advice do I have if somebody's considering it?
yeah. What's your advice for those who are considering hormone replacement therapy?
If somebody really is considering it, maybe they're in menopause or perimenopause, I would say go find a knowledgeable practitioner. When people in the community ask me, who should I go to? I'll direct them to the Menopause Society
Ah,
website. So menopause.org. And they have a find a practitioner button. And you can see, there are practitioners on there who are MDs, NDs, NPs, midwives, a range of providers. And some of them, I was a member before I was certified. So some of them are members, meaning they have an interest and they do this a lot. And then those who are certified menopause practitioner will have like their seal on their name, and it'll say MSCP after their name. So those providers just have done the education and they stay up to date on all of the options available for all of the people. So I would find a knowledgeable provider. I would start tracking my cycles if I'm still having them. A lot of people come to me and they're like, I have no idea. And it actually matters. I need to know what your cycles are doing. So if you're thinking about it and you're still cycling, track your cycles. How long are they from day one to day one? You know, how many days of bleeding? What are your symptoms when you're bleeding? When do you feel your best? When do you feel your worst? Track that and be ready, you know, to just be ready to receive a lot of information, you know, and maybe study up before you go. Books that I love are Estrogen Matters by Avril Blooming and Carol Tavris. Excellent book. Very, very unbiased examination of estrogen's history and safety and efficacy for different conditions. I really love Kelly Casperson's new book, which is The Menopause Moment. It is an excellent reference guide. And then Heather Hirsch just came out with a new book about perimenopause. I think it's called the Perimenopause Survival Guide.
Wow.
Those are all great resources.
Amazing.
Read up.
And read up on it because it's about your body, right? Mm-hmm. And because we are living so long. I mean, people who will live to be 150 years of age have already been born. That's according to the AMA. So like, we're just going to be living a long time. And so we want to take really good care of our bodies and our brains and our organs and our heart and our bones so that we can be happy and athletic and healthy and enjoy our time here.
Well, and on that point, you know, I think you and I have chatted about this. I'm a huge advocate for women lifting weights.
Yes.
And I think this goes along with the same conversation, you know, say a woman is like 45 or 55. Do you want to be able to get off the toilet by yourself?
Right.
In 15 years?
Right.
It'd be that soon that you don't have the ability to.
Because muscles start depleting in our 30s. And I wasn't lift weighting until you told me to. I was taking Pilates. I was playing pickleball. I was walking my dog. And I was doing all of that because I have 6 grandchildren and, you know, they like to climb on furniture and jump on my arms, or they want me to carry them on their back. And I want to do all of those things. But when you made that recommendation, Marie, some weightlifting, there was a big difference in my body when I started to, and I do the perfect workout where it takes like 20 minutes because it's as you push, you're pushing. And then as you pull back, you're resisting. So you get the exercise done much faster. It's made a huge difference just in my balance, my strength, opening up jars, just everything. And now 2 grandkids can jump on top of me and I'm not going to fall to the ground or hurt my back. You know?
I love that. Yeah, it's so important. That's one of my key motivations is I have a 5-year-old daughter, as you know, and she was born with some disabilities. And sometimes I have to be able to carry her, and she's almost 50 pounds now. And I'm probably going to have to carry her for a while. And we live in a 2-story house, right? So like I need to be able to hold my 5-year-old and like whatever stuffy she has demanded upstairs with, you know, and I need to be able to do that safely without injuring myself or her. And with the whole hormone conversation, it's in the same vein. And I can't claim this is from Dr. Casperson, but when you outlive your vision, we don't tell you to suffer. We give you glasses or contacts. You know, if you need a hearing aid because you've lost your hearing, but you still have time left on this earth, we're not going to deny, you outlived your ears. Too bad. Well, we're outliving our ovaries. You know, why is that any different? If you outlive your ovaries, you replace the hormones so that you can continue living at that same vital level.
Yes. So that when you travel around the world, no matter what your age is, you can walk the whole time and carry your suitcase and gelato or whatever else you have and truly enjoy yourselves. How can people find you, Dr.
Oh,
Ghajar?
yes. So I practice in the Wallingford neighborhood in Seattle. I'm in private practice. It's just me for now. And I'm online, dralishaghajar.com. It's very easy to find me there. You can Google me. I'm on the Menopause Society website as a certified menopause practitioner. I'm on Instagram, although I'm horrible at but you can find me at Dr. Alisha Ghajar on Instagram. And I'm a member of the Washington Association of Naturopathic Physicians. So sometimes people find me there if they're specifically looking for an ND. I'm all over, really.
And if someone's not living in our state and let's say they may have a practitioner who could prescribe for them, but they would love to have your consultation, you can do that, but their practitioner would have to, order whatever they agree upon per the consultation. You can also do that as well.
That's right. I can't prescribe out of state. Unfortunately, I would love to, but I can't. I can only prescribe in Washington. But on occasion, if somebody just wants to understand their options, then I'm happy to answer their questions.
Good. Yeah. Great. Well, thank you so much. I can't believe it's been a little over an hour, actually. We've been talking and it's been a complete joy. I've learned a ton. I will no longer say that it's all horse urine. That's the old, because most people don't prescribe Premarin anymore. I mean, I know it's still available, but it's very rare when I hear someone tell me they're taking Premarin. I'm like, what? But yeah, it's rare. Right.
Yeah. This has been a pleasure. Thank you so much, Marie. I love and respect all the work that you do. And it's always a pleasure to chat with you.
Thank you. It's mutual. Love and respect all that you do in the world. Thank you so much, Dr. Ghajar. And have a beautiful day.
Thank you. You as well.
Thank you.